So this talk, I already kind of laid the foundations for what causality and causal inference means. And I will kind of expand on that in this particular presentation. So I already told you of the three types of knowledge, causality is what every epidemiologist is fundamentally concerned with. Is there a relationship between some exposure and some outcome of interest? Okay, all our research aims to clarify that fundamental causal link between an exposure and an outcome. So what is the cause? This is a classic definition by two famous epidemiologists, Ken Rothman and Sandra Greenland. Every word here is important. Cause of a disease event is an event, condition, or characteristic that preceded the disease event and without which the disease event either would have not occurred at all or would not have occurred until some other time. Okay, so keep in mind, for a cause to be a cause, it must precede the disease event. Okay, smoking must happen before lung cancer. Okay, exposure to COVID must happen before the disease occurs. Temporality is important. Okay, time sequencing is a very important issue element of causality. Secondly, the way the definition is set up is that without that cause, then either the disease event would not have occurred or would have occurred some other time. Okay, and I will talk more about the issue of a causal contrast. Unfortunately, public's understanding or how media portrays cause and effect is extremely naive, right? This cartoon is like a joke showing, the correlation between clothes and global warming. But we can also see that we are starting to see very similar media reporting and preprints, right? Is BCG silver bullet, right? A game changer against COVID. On the basis of what? On the basis of early preprints like this, which merely show an ecological country level correlation between BCG vaccine and COVID, right? So I would argue that these headlines are misleading and should have been a lot more toned down than what the paper actually suggests, right? Smoking. I mean, I was blown away that the Economist magazine ran a headline which is completely boggles my mind, based on a cross-sectional study, which is one of the weakest epidemiological studies, full of potential selection bias and confounding, and yet the Economist ran a story that smokers seem less likely than non-smokers to fall ill with COVID. To me, this is irresponsible reporting by the Economist. So, going to the question of what is a cause, cause must always precede the disease. That's an absolute non-negotiable requirement for it to be a cause, which means if it is a cross-sectional study where the exposure and disease is measured at the exact same time, you really cannot tell which came first, which is why inherently a cross-sectional survey goes down in the hierarchy of evidence. I'll show you the pyramid or hierarchy of evidence in a second. When you cannot tell which came first, you will never make causal claims. You should not make causal claims because you don't know what came first and what came later. Okay. So for example, did I begin exercising after I had angina? Right? If you measure me and you check for my angina and you ask me about my physical activity, you don't know whether I began exercising after I developed angina, right? Or was I exercising well before I developed angina? A cross-sectional study will never tell you because it measures exposure and disease at the same time, okay? And the second requirement for a causal, for us to decide on a cause is that we always set up the cause as a causal contrast, okay? And the way we think about it is this, epidemiologists have this tongue-in-cheek way of saying, You can tell an epidemiologist because if you ask them something, they will always put back a question to you as compared to what. Okay. So in an old movie, the comedian Groucho Marx is asked, "So how's your wife?" And so Groucho says, "Compared to what?" Right? So this is a tongue-in-cheek way of saying we are trained in epidemiology to always pose something as cause only in terms of a causal contrast or a comparison. Okay, so we will never say, for example, healthcare workers have this risk of developing COVID. Okay, because by that group we do not have a complete sentence. We will always say healthcare workers have this risk of getting COVID as compared to the general population or as compared to non-healthcare workers. Who are you comparing with is inherent in a causal contrast because without that comparison, we can never quite tell. So I think one of your first quiz questions was if you gave someone chloroquine, you had no control group, right? And let's say 80% get better. You will never be able to attribute that to chloroquine. Why is that? Because let's imagine you never gave anything. 80% of COVID patients still get better. Then you don't know whether the 80% you saw in the chloroquine group was merely the natural history of the disease versus the effect of chloroquine. The only way to resolve that question would be to have a control group that is similar, did not get chloroquine. So that's why uncontrolled studies simply cannot get at the causal contrast because we don't know what would have happened if chloroquine was not given, right? So even within randomized trial, there are randomized control studies, there are randomized uncontrolled trials, and an uncontrolled trial on remdesivir published in the New England Journal of Medicine still left you scratching your head on whether remdesivir is working or not because there was no group that did not get remdesivir in that study, right? Small uncontrolled remdesivir trial. Everybody was wondering what the hell was New England Journal thinking publishing that because it gives you no insights into what is going to really happen with remdesivir. You have to have a controlled study where there's a group that did not get remdesivir to figure that out. So causal contrast is invariably set up as a contrast, right? Contrast means if you are exposed to that particular exposure, what would happen? And if the same population in the same period was not exposed to that factor, what the outcome would have been. So we want the outcome in the same population, in the same time, one with the exposure and the other without exposure. So I'm going to explain to you visually. Okay. This is the dream situation for an epidemiologist. Okay. We call it the ideal counterfactual comparison to estimate the causal effect. Okay. Let's say the exposure is smoking. The outcome is COVID-19. Okay. We have a population. We call it a cohort. Okay. And I'll define a cohort next class. It's a group of people. Okay. And then we call it an exposed cohort. Exposed means, say, exposed to tobacco smoking. Okay. Here are a bunch of smokers, and we follow them up over time. Okay. Prospectively. And we get I sub exposure. Incidence of COVID-19 in the smoking cohort. Okay. Again, incidence is the rate at which new disease events occur in the cohort. And you will get an entire lecture on that next class. Okay. For now, think of it as the risk of developing COVID if you are exposed to tobacco smoke. Now, in the same time, not next year, not the year before or the year after, during the same time, if we could get the same group of people, but now they are not smokers. Same people, okay? Same genetics, same DNA, same physical characteristics, same genetic history, same past history, everything is the same. Now you follow up that cohort, you get a Second incidence, this is the incidence in the unexposed cohort, incidence in the non-smoking cohort. But these should be the same two groups. I want this group and this group to be identical, except for the fact that one, everybody smokes, and in this one, nobody smokes. And we call that counterfactual. Why is it counterfactual? Because it is impossible to observe this situation. Somebody is a smoker at that point, or they're not a smoker. They can't be both, right? That's why we're saying counterfactual means contrary to fact. If you could observe the same cohort to be non-smokers, what incidence would you have got? If by chance you could get this contrast, you divide one incidence by another, what you see is a true causal risk ratio. Incidence in the smokers divided by incidence in the non-smokers. Let's say that ratio is 2. That 2, risk ratio of 2, is a causal risk ratio which summarizes the association between tobacco smoking and COVID-19. Okay? This is the dream world which every epidemiologist would love to see. But this is a dream world that not a single epidemiologist has ever seen, right? Because this counterfactual simply is incompatible with reality. Okay, so this is the first ideal causal contrast that we would like to see, but in reality, this contrast will never be seen. But if you could see it, this is ideal for what reason? You can tell that the initial conditions are identical in the exposed and the unexposed group because it's the same period, same population, same genetics, everything else is the same. So the only difference between the two is the fact that one smokes and the other does not smoke. That's why smoking is the only possible explanation for the risk ratio of 2. Okay? Nothing else can explain it. Not genetics, not exercise, not socioeconomic status, so on and so forth. Okay, so we get it. We cannot really see this. It's impossible to observe unless you go to some of these movies. If you are a Harry Potter nerd fan like me, you will remember how Hermione Granger went back in time with a time turner, and then she managed to save Sirius Black in the counterfactual situation, right? There are other movies as well which have that same counterfactual flavor, right? You see something and then you see the outcomes in a different situation. I think Groundhog Day is a good example where you see something happening and you rewind the clock and you see something happening, but the outcomes are very different between the two situations. In reality, we have to compromise, okay? And the compromise we can do is we have a bunch of people who are smokers, and we can definitely get the incidence of COVID among the smokers. Now, instead of the counterfactual cohort of non-smokers that we want to follow up, which we cannot follow up, we go get a completely extraneous set of people. We now have a second group of people who are not this group. Different genes, different characteristics, different profile, different risk factors. But we want that to be a substitute for the counterfactual that we will never be able to observe. So now we have a non-smoking cohort that we have put together, and we're hoping as hell that this non-smoking cohort can be a great substitute for the unobservable counterfactual cohort that we really want. So the job of this control group or the unexposed non-smoking cohort is to be as close in approximating to the counterfactual that we really want to find. Now, in this cohort, we will get an exposure incidence, and now we can compute the risk ratio of the incidence in the exposed group and incidence in the substitute cohort, and we will get a risk ratio. We are really hoping that this risk ratio for the association is coming close to the causal risk ratio of 2 that we would have got if we could truly get the counterfactual situation going. Now, what is problematic in this is that you're hoping that this cohort of unexposed people are as similar to the exposed cohort but for smoking, unfortunately, they might not be. There may be many characteristics that make the smoking cohort different from the non-smoking cohort. For example, if you're smoking, you may be more likely to drink. If you're smoking and you're drinking, you may be less likely to exercise. And if you're doing both, you may be not taking your aspirin daily. Whatever the issues are, in reality, the initial conditions are different, which means this way of getting at the truth is fraught with the dangers of selection bias, confounding information bias, which is how we end up. Because we cannot get the causal contrast, we have to settle for getting a non-causal association, and we're hoping like hell that the study design in some ways gets us close to the causal association that we would have gotten if we had the counterfactual. So the best epidemiological study will be the one that captures the true causal effect with the least amount of distortion, right? Any study that can take you to this counterfactual dream world is a good study, okay? This is where we want to be. This is gold. If we can't get this, anything we do after that is an exercise in trying to make this as close to the dream counterfactual situation that we want to be. So obviously, a case series or an ecological study or a cross-sectional study will never ever get close to the counterfactual. Randomized trials are the only design that comes close to mimicking the causal contrast, and that's why we call it the Hubble equivalent among the epi study design. No study design has the ability to get close to the counterfactual situation than a randomized control study. Not just a randomized study, it has to be a control trial. Okay, control group is absolutely fundamental, right? So in an experimental study or a randomized trial, and there will be a whole lecture on this, you take eligible people, let's say people with confirmed COVID-19, you randomize them to hydroxychloroquine or a placebo, or remdesivir versus a placebo. You follow up both groups and see what proportion of them live, die, have ICU admission, ventilators, no ventilators, whatever your outcomes of interest are. The whole process of randomly allocating some to remdesivir and some to placebo makes the two groups comparable. You do not handpick who gets remdesivir. No clinician should be allowed to handpick who gets remdesivir. No nurse should decide who gets chloroquine. You allow a random coin toss, so to speak, to decide who gets into the remdesivir arm, who gets the placebo arm, who gets into chloroquine, who does not. It should be a completely random allocation to the two. And if you did that, the job of the randomization is to make the two groups comparable as far as initial conditions are concerned. And when you make them comparable, you're getting close to the counterfactual truth or a causal contrast that I showed you earlier, right? This was one of your quiz questions. What does randomization really do? And what it does is to try and make the treatment and the placebo group as similar as possible. Now, failing a randomized control trial, if you did a observational study, let's say a cohort study, you take a bunch of people who are already taking hydroxychloroquine, and then you see what their outcomes are. You take a bunch of people who are not on hydroxychloroquine, you follow them over time, and you compare the mortality difference. If you did this study, you are constantly now asking, but why did somebody get onto hydroxychloroquine in the first place? Is it because they were sicker, right? Is it because they could afford it? Is it because the doctors decided they were older or they had other risk factors? You can never really say initial conditions will be identical in the chloroquine and the non-chloroquine group, which is why observational studies on drugs are invariably problematic. because you can never quite balance the variables between the people who are on the medicine, who are not on the medicine. I can tell you right off the bat that anybody who is on a certain medicine or an intervention is inherently different from others who are not. There is simply no way around this, right? For example, I'm a pre-diabetic, okay? And I went and asked to be put on metformin because my dad and all his brothers died of diabetes. I'm terrified of diabetes. I don't want to get diabetes. I want to prevent diabetes. So I decided to take metformin, even though I'm just pre diabetic and not diabetic, right? But I'm not going to stop with just metformin. I also exercise. I also go get my blood sugars checked. I don't smoke. I do a whole bunch of things that I might attribute to metformin, but might be other things that I'm doing to prevent me from becoming diabetic, which is why taking people like me, everybody who's on metformin compared to those who are not metformin is fraught with problems, will never get you close to the counterfactual situation. If I did not take metformin and I could compare my risk of diabetes with what I'm at risk for now with metformin, that would be the dream counterfactual. So you can see here, meta-analysis of consistent randomized trials would be top of the pyramid of evidence. That's like the gold standard as close to we can get. So if there are 5 trials on remdesivir, ideally independent of Gilead, they're all randomized, double-blinded, placebo-controlled trials on remdesivir. And if we meta-analyze those 5 and they show, say, a 50% protection from mortality against COVID, man, that would be dynamite. Now you would say, okay, I want to go on remdesivir. Okay. Failing that, you take a single randomized control trial on remdesivir. And if it's well done, high quality, large, adequately powered, then that will be the second way of saying, okay, remdesivir might be doing some good. But once you're into cohort studies and case control studies on remdesivir, your evidence level has fallen dramatically for all the reasons I told you about. You never know why somebody got remdesivir. You never know what other things they're doing that makes them different from others. Lots of confounders, tremendous scope for selection bias. Once you're down to cross-sectional studies, ecological studies, expert opinion case studies, it's completely hopeless. You would never, ever even talk about remdesivir working or not working on the basis of such inferior, poor quality study designs, right? Nobody in their right mind will use an expert opinion to decide on remdesivir is working or not. Not 8 case studies, case reports published in New England Journal of Medicine, anecdotal observations. None of that is worthy of any kind of serious consideration when it comes to the hierarchy of evidence. Okay. Now, I don't have much time. We just have 10 minutes to go. I'm going to quickly walk you through how we think about causality in epidemiology. Okay. There is a very nice approach suggested by Ken Rothman called the causal pi model. Okay. And here, let me explain how the causal pi model works for you. Okay. In a causal pi, we're basically saying for a disease to happen, okay? So let's say in my case, I'm worried about diabetes, okay? Let's say for me to develop diabetes, several things need to click in place before I end up with diabetes. We inherently think of causes as multifactorial. We rarely think of any one thing causing diabetes, one thing alone making someone die of COVID. It doesn't work like that, right? This entire model assumes that causality is multifactorial. You need multiple things to fall in place before something catches fire. Okay. For example, one of the reasons why I will end up getting diabetes, I think in future, is because of an extremely strong family history, right? Dad died of diabetes. Every one of his brothers died of diabetes. So that genetic factor, let's say, is factor A. Think of the cause as a pizza pie, with each slice of the pie being something that needs to click in place before that person develops that disease. So for me, for my pizza slice, my family history is piece number 1. Okay. Second piece could be me being overweight. Okay. That needs to click in. Next comes maybe a piece would be me not taking metformin. Okay, not taking metformin, not doing something. That could also be a causal component. Then the next piece is I'm not physically active, right? When these four things click in place, boom, that's the time I end up with diabetes, right? So this is my causal pie. And if all of that clicks in, that is enough to cause diabetes in me, I call that as a sufficient cause. Four things for me is enough to cause diabetes. Maybe for you, you need six things to click in before you get diabetes. So your sufficient cause might be different from my sufficient cause. And a component cause or a risk factor is each of the slice of the pie, right? Family history is a risk factor. Obesity is a risk factor. Smoking is a risk factor, and they may all have to click before you end up with diabetes. Okay? This would be a beautiful method for heart disease, for cancer, for COVID-19, whatever it is you want to think for, right? One causal mechanism is a sufficient cause. It may have 4 components, 5 components, 8 components, 16 components, doesn't matter, right? So you understand how this is shaping out to be. Now I'll give you a COVID example. I think, and you know by now, that there are many, many ways of getting COVID and dying of COVID-19. There is no one uniform approach. Okay. For example, this person gets COVID and dies of COVID because A, she is elderly. This is absolutely happening right now in Montreal as we speak. 80% of Montreal COVID deaths are among those living elderly living in a nursing home. Okay. Elderly person exposed to coronavirus, already is a diabetic, lives in an elderly nursing home. Boom. That's enough for that person, woman, to end up with COVID-19. So this is one sufficient cause. But everybody who gets COVID will not fall into this profile. This is certainly a big part of the story in Canada, but this is not how things are playing out in India. So you may have a second causal pie. Now you're a health worker, let's say in Sion Hospital. You are maybe in your 40s or 50s, you have cardiovascular disease, or you may have be working in New York, you are black ethnicity, and you're a male. If these things click in place, now you have COVID-19. Lots of health workers in America, for example, have had COVID because of this particular profile. And it's very different from this profile that I showed you. That's one sufficient cause to get COVID. Second sufficient cause. Here's a third one. Asian, has pre-existing cancer, low socioeconomic status, and is obese. That profile could cause COVID-19, right? So this sufficient component cause model is a very nice way of thinking about causality. It also helps us figure out which risk factor is important in which community. It also helps us think about what will happen if we removed one risk factor alone to prevent that causal pie from forming in the first place, right? Even if you take out one piece of the pie, the entire pie is not complete. You will not get the disease, right? I think the trick in epidemiology is to identify the modifiable risk factor, removal of which will dramatically reduce the risk of getting the disease, right? We're constantly hunting for that, and we have different ways of computing that removal of exposure, right? We call it population attributable risk. For example, you could say a large proportion of tuberculosis in India is attributable to malnutrition. Malnutrition is not the only slice in this tuberculosis pie, but removing malnutrition can dramatically result, say, reduce a third of India's TB burden. Then that's an important risk factor that you can act upon. Okay, and sufficient means sufficient cause is each pie, and there are multiple sufficient causes. A necessary cause is one which shows up in every single causal pie, right? For example, if you're not exposed to coronavirus, you could never get COVID, right? But coronavirus exposure alone is not enough to cause actual COVID disease or die of it. You need other things to also happen, right? So we say coronavirus is a necessary cause of COVID-19, but it may not be the entire pie. You need elderly, age, smoking, obesity, or whatever to complete the pie. But coronavirus is a necessary cause because it appears in every single pie of COVID disease. Okay? And then you can also think of this causal pie model as a beautiful way of understanding timelines in disease evolution, right? All of us know cancer, for example, can take decades for somebody to end up with cancer. But the ball that got started rolling may have happened long time ago, right? You may be born, say, for example, I was born maybe with a genetic predisposition for diabetes. So one of the slice of the pie I had given to me on the day I was born, right? At conception. But that's not the day I got diabetes or will get diabetes. Then as I grow up, I'm exposed to other things that click in place over time. And by the time I reach 55, say, age, that's when the last piece clicks in. That's when diabetes becomes apparent in me, right? It can take decades for every piece of the pie to fall in place before the disease manifests. That total period is called induction period. Induction period could take decades. Induction period could take weeks, depending on the disease. It's the it's the time lag between the first component cost coming in to the last component cost clicking in, and then disease becoming evident. Okay. Induction period is not the same as incubation period. Incubation period is something we use in infectious diseases. It's the time between the first exposure to someone with coronavirus, okay, contact, to onset of symptoms. With COVID-19, it's about 5 to 6 days is the incubation period. Latency period is a slightly different concept. You could have prostate cancer, but that is not when you get diagnosed. There's often months of delay before prostate cancer causes enough symptoms and then get diagnostic workup and get picked up. So latency period is between when disease first happens in the body to when it is actually detected or diagnosed. Okay. Now with COVID-19, there is this phenomenal iceberg phenomenon problem that we all need to understand. There are people who are exposed who actually never get infected, right? You may be one of them, I may be one of them, I don't know yet, right? So we are exposed to the virus, but we completely are immunized already naturally, okay? Or we may be infected with the virus is in our body, it is replicating, but it's caused zero symptoms in us, okay? Some of us may be in that category. Then they're infected, and then we actually display symptoms. Cough, fever, sore throat, muscle pains, loss of smell, what have you, what have you. And then even among that group, very few get tested. Even with classic symptoms, it's very hard to get testing anywhere in the world right now, right? There are very rigid criteria for testing. So then you get tested. And then the tests are not accurate. Tests have their own sensitivity, specificity. Then if the test is positive, you're called a confirmed COVID-19 case, confirmed by PCR. And then not everyone with confirmed COVID will die. Small proportion will die. That's case fatality. That is the tip of the iceberg. So if you say Mumbai city is reporting 100 COVID-19 deaths in a day, you take it that that 100 is at the very tip of the iceberg. It's a tiny piece that is visible, and there's a massive iceberg at the bottom that you're not seeing. For every one COVID death, you're looking at thousands of people who might be infected but not displaying symptoms. And understanding this difference between exposure, infection, and disease is quite important because it totally changes on what you're talking about. Are you talking about just COVID deaths? Are you talking about only confirmed cases? Are you only talking about PCR confirmed cases? You're talking about clinical cases? Are you talking about people with antibodies who are not symptomatic? Everything depends on how you define it. So COVID-19 is a beautiful example of the iceberg phenomenon, and this is true even in tuberculosis. Okay. Now, last couple of slides. So we do not take a single study and say something is causal or not. I just told you it took us decades worth of research to say for sure that smoking is a causally associated with lung cancer, or that Helicobacter pylori infection is causally associated with gastric ulcer. Okay, so the way Bradford Hill is a famous British biostatistician came up with a list of what he called criteria. We now call it Hill's criteria. Okay, so he says look at the strength of the association. Bigger the risk ratio, more likely that this is a causal association. So the relative risk for tobacco smoking and lung cancer is in the order of about 10. Okay, smokers have a 10-fold higher risk of lung cancer. That's a much stronger association than a 2-fold relative risk. Okay, so stronger the association, more likely to be causal. Consistency. Do you have 4 different studies, 8 different studies consistently showing that the same phenomenon is happening? Specificity. If something is highly linked to one disease, it gives you confidence that this is a very specific link between something and something. Like BCG should protect against TB, but why would it protect against COVID-19? So some of us don't see it as a specific finding. That's why we are less excited about it, right? Temporality. Remember, cause must precede the effect. Okay, temporality has to be guaranteed. Dose response. More packs of cigarettes you smoke, if you find a nice linear association, right? Greater the smoking, greater the risk of lung cancer. That gives you reassurance that that gradient you see is more likely to be causal. Plausible. We talk about biological plausibility. Maybe there's mouse studies which connect how tobacco smoking actually changes the lung tissue and elicits carcinogenics, so on and so forth. Coherence. Animal research, experimental research, observational research, toxicology research. When it all converges, you have greater and greater confidence that this is causal. Experimental evidence. You make people stop smoking, smoking cessation, and then you demonstrate that you can reduce their risk of lung cancer. That is very powerful. Okay. And then analogy is you have an equivalent. So, for example, we know smoking is bad for virtually every single lung infection. That's why we refuse to believe, people like me, that tobacco smoking can protect against COVID. It makes no sense to us by analogy, right? So we look for similar associations to kind of make sense of all of this, right? So this is how we use causal criteria, and I won't read this, but you can see all the research done on Helicobacter pylori mapped against the 9 Hills criteria, right? It's because of all this research done, we know it's rock solid that H. pylori causes duodenal ulcers, okay? And again, single studies are never, ever, even if it's the best randomized trial in the world, I would be terrified of using a single trial to make a decision on whether something works or not. What if that single study has some serious fatal flaws in it or a bias in it, right? So that's why I always want to see more than one, and I like to see enough consistent studies before we make a causal claim, right? Correlation is not causation is a cliche that has been used any number of times by any number of people, but in this pandemic it's just complete madness to see the number of random correlations being thrown around and the number of people who are taking sides in rival gangs already, right? There isn't a day that goes by where somebody tries to convince me why BCG should be given to the whole world right now to prevent against COVID, and I keep trying to calm them down that the evidence on BCG is nowhere close to being causal, right? All it is a correlation, right, based on very weak studies. So we are very sanguine about not confusing correlation to be causation, right?